Hi everyone, and welcome back to another episode of Olivia Squared. Today we'll be discussing hereditary hemochromatosis, so let's get right into it.
Bill Nye the Science Guy. Bill Nye the Science Guy. Bill Nye the Science Guy.
Science rules.
Bill Nye the Science Guy.
Inertia is a property of matter.
Bill Nye the Science Guy.
T minus 7 seconds.
Bill Nye the Science Guy.
But first, why does this interest us?
Well, we've been talking about the genetic mutations in class and the different places that they can occur. Hemochromatosis is a great example of how genetic mutations can cause a host of problems.
Hemochromatosis is a disease in which the body absorbs too much dietary iron, which leads to buildups in tissues and organs that can be very dangerous. Hemochromatosis is the most common hereditary disease among the Caucasian population. The disease is seen mostly in people of Nordic or Celtic descent, with approximately 1 in 220 to 250 people affected.
The figure here shows that the gene defect that causes hemochromatosis substitutes the amino acid cysteine for the amino acid tyrosine at amino acid position 282. The defect is seen in 80 to 85% of cases of hemochromatosis.
There are two other forms of the gene defect. One substitutes histidine for asparagine at position 63, and the other substitutes serine for cysteine at position 65. The proteins that are then made from these genes are defective and cannot properly regulate iron levels in the body.
So there are 3 stages of hereditary hemochromatosis. Stage 1 refers to the patients that have the genetic disorder but are not showing signs but have the genetic susceptibility.
Stage 2 are patients that have the genetic disorder that show the physical characteristics and symptoms of iron overload due to their genetic makeup, but they're without tissue or organ damage.
Lastly, stage 3 patients are those that have the genetic disorder with iron overload so severe that the patient experiences damage of the tissues and organs.
Next, we'll dive into the complications that can result from this iron overload. Olivia, care to take it away?
Sure thing, Olivia, but let me warn you folks, these aren't going to be pretty. So the first is that the disorder can result in the suppression of the iron-regulating hormone hepcidin. Hepcidin is considered the principal iron regulatory hormone, and altering the regulation of hepcidin helps hemochromatosis pathogenesis. Inducing hepcidin production with excess iron causes the intestines to decrease its iron absorption and inhibits the iron release from macrophages.
Oh geez, that can't be good. I've heard that hemochromatosis also alters the function of HFE proteins.
Really? Tell me more about it.
Of course. The HFE protein consists of 3 loops that contain disulfide bonds in the second and third loops. Though the function of these proteins are mostly unknown, some suggestion says that the protein acts as an iron sensor on the membrane of the hepatocyte. HFE then binds to a transferrin receptor and influences the expression of hepcidin.
Wow, I've also heard that liver damage results from iron overload, and studies have even found that the overload can inhibit the membrane-dependent functions of the lysosomes and even the mitochondria, causing damage to cells and tissues.
Oh no, not the powerhouse of the cell! How might a patient know they have hereditary hemochromatosis?
Well, if your family has a history of hemochromatosis, you're at a higher risk for having the disease. You'll be evaluated and screened by your doctor usually, and diagnosis is based on documentation of increased iron stores.
You can also be tested for hemochromatosis if you present symptoms such as fatigue, impotence, abdominal pain, and decreased libido.
To treat hemochromatosis, phlebotomy treatment can be used, which is the removal of blood from the body. 1 unit of blood contains about 200 to 250 milligrams of iron, and patients should have blood removed 1 to 2 times per week.
Well, thanks for tuning in to another episode of Olivia Squared.
Catch you later!